20 minutes. So I think, Mirza, will you share your screen?
Yes. Hello, can everybody see it?
Yeah, we can see.
Okay. I will be, thank you for the kind invitation and hello everyone. I will go quickly over the leg pain and lumbar radiculopathy. We have published this or a part of this in our lumbar disc herniation epidemiology, clinical and radiological diagnosis as a WFNS spine committee recommendations in 2024. This is open access manuscript, right, like all of our recommendation, and I sincerely recommend to everyone who is in this webinar and to all residents and students who are interested in neurosurgery and different aspects of spine surgery to read these papers. So I will start with a case which I've operated on recently. It was a 38 years old female patient. She has a leg pain with radiation into the dorsal fig and dorsal lower leg, as well as into the fourth and fifth finger on the right side, her toes. And she received first an X-ray in an external institution. The first thing which we saw on X-ray is that she has a lumbarization of the first sacral segment, that she has six lumbar vertebrae. And this is something, this is, in my opinion, the first step when you want to correlate the certain symptomatic that the patient has with the patient's symptoms and with the imaging to first to see if there are any anomalies on the lumbosacral area. So afterwards, she received an MRI and she had this lumbar disc L5S1 on the right side, but she also had one disc in the same height, L5S1, on the left side, and she had a typical S1 radiculopathy. And since she had only S1 radiculopathy on the right side, we have performed a right-sided nucleotomy and sequestrectomy via hemilaminectomy. This is an image of one of possible positions for herniated disc surgery. This is not the subject of today's talk, but for the completeness of this case, I wanted to show it. And this is the way we do these surgeries. It's a standard surgery. Microsurgical, there is also an endoscopic removal, which gained attention and popularity in the last years. But anyway, the one point of the surgery is to remove a small part of the bone, to provide a hemilaminectomy, flavectomy, to find the dural sac, find the nerve root, and to remove the herniated disc. And there are actually three X-rays which are important to do during the surgery. The first X-ray, the positional X-ray, to find the where to place your skin incision, where is the disc. The second X-ray during the surgery, where you put your retractor. There are different types of retractors, and the third X-ray when you put your hook into the disc space. And this is one image from our surgery with the dural sac and nerve root, herniated disc. So this is on the right side, this very patient with L5S1 herniated disc. So this is another scheme. What is very important is to understand the spinal anatomy. So if you really are trying to make a correct diagnosis of the leg pain, actually of back pain, which is radiated into the leg, it's very important to know the relationship between the vertebrae, the joints, the discs, and the nerves, and to know what does every radiculopathy actually make for symptoms. So every radiculopathy means actually that the certain nerve root is under compression or under pressure from the herniated disc or the facet joint. And every compressed nerve root has its own very specific symptoms. These are the percentages of how common herniated disc and radiculopathy at each level is. And it is also very important to understand the neuroradiology and the neuroanatomy of the lumbar spine in order to correlate a certain symptomatic to a certain pathology which you find in your MRI scans. So patient always needs to be asked on pain radiation intensity in relation to position. Is it more in standing, in sitting, in lying? History, does it have an onset, which is acute or chronic in back pain and in leg pain? It's very important to know, is there any malignancy in that patient, or does he have any signs of infection? Because the spondylodiscitis, infection diseases, as well as metastasis, always need to be a part of our differential diagnosis. Laboratory, motor and sensory assessment, bladder and bowel incontinence questions, reflexes, are there any pressure pains, for example, in facet joints or iliosacral joint? Is it a positional pain? And differential diagnosis always needs to include hip pain. We have a lot of patients who have positive so-called LaSague signs, and they actually have a hip problem. And for neurosurgeons, it's sometimes not easy to think on hip problems. That is mostly the case in orthopedic surgeons. Differences between spinal and vascular claudication, or does a patient have pain in extremity due to fracture, and of course the imaging. So when it comes to lumbar radiculopathy, L3, L4, L5, and S1 radiculopathy is very characteristic. L3 radiculopathy is a pain in back which goes through the anterior thigh up to knee. In L4, it goes over the knee up to the foot. In L5, it goes very characteristically into the thumb, and in S1, it goes on the posterior side of the leg. And of course, they have they have a weakness, L3 in quadriceps and L4, L5 in anterior tibialis, and S1 in gastrocnemius. And there are also certain reflexes which are lost at a certain level and for the certain radiculopathy. And in many cases, if you have an isolated herniated discs, you also have a very specific radiculopathy, like demonstrated in this in this table. And there are the signs which you always need to examine in every patient: LaSague, Bragard, and pseudo-LaSague Zeichen. Pseudo-LaSague Zeichen is when you stretch the extended leg more than 45 and then produce a pain. That means that is a pain of the back muscles and not actually a real radicular pain. But until 45 degrees, if you provoke a pain by raising an extended leg of a patient, that is usually a sign of the compression of the nerve root, which is under pressure of the herniated disc. And this is also very pathognomic for herniated disc disease. So these are now the different techniques with which you can do it, but these signs are very important in your differential diagnosis prior to imaging. So L4 usually makes problems in leg extension and quadriceps, and sensory problems in medial knee and shin sensory loss with pain down anterior thigh. L5 is the paresis of extensor hallucis longus, big toe extension, hip abduction, and ankle dorsiflexion, with sensory loss in big toe and pain down back of thigh and lateral gastrocnemius. And S1 makes gastrocnemius and ankle plantar flexion and loss of Achilles reflex, and sensory loss of lateral foot and pain down back of calf. So one very important thing which we see very often, that even some students and residents don't comprehend early enough in their training, is the relationship between vertebra's neuroforamina and the herniated discs. So herniated disc L4-5 leads usually to L5 radiculopathy, but through L4-5 neuroforamen, the L4 nerve root leaves the spine. And intraforaminal or extraforaminal herniated disc L4-5 will therefore lead to L4 radiculopathy. And this is very different than in the cervical spine. In the cervical spine, you first have the nerve and then the vertebra. And in lumbar spine, when you count it, you first have the vertebra and then the nerve. And the herniated disc always or very often makes symptoms on the nerve root, which goes one level below. And this is, in my opinion, a very, very important figure and a very important thing for everyone to understand. Here we have it also on the lateral side. And this is an axial T2 weighted MRI of the lumbar spine, which shows these relationships. You have L5 roots. This is the L4-5 level. You have L5 roots. So usually this herniated disc will lead to compression of the L5 because these herniated discs are usually medial or medial lateral, but you have a far lateral disc or an intraforaminal disc that will lead to compression of L4 roots. Other type of pain which is caused in back and in the legs is the pain due to spinal canal stenosis, due to thickened ligamentum flavum, narrowed spinal canal, facet and hypertrophy. And it is very important to make a distinction between lumbar spinal stenosis with neurologic claudication and the vascular claudication and other causes of pain in the legs and in back. So lumbar spinal stenosis with neurogenic claudication is usually pain when standing, with pain or numbness in the lower back when standing upright, pain when walking. These patients usually need to make a pause while walking after 50 to 100 meters because their hypertrophied facet joints are making compression on the dural saccade and the nerves. Pain when sleeping, when laying down, which may be relieved by curling into the fetal position. Some patients with severe spinal canal stenosis do not have problems while riding the bicycle because that opens up the neuroforamina and opens up the spinal canal, and relief in forward position with temporary relief when bending forward while sitting or standing as pressure on the spinal nerve is released and space in the canal is opened. And common actions are finding a chair, leaning over a shopping cart, using a walker or a cane. So for leg pain and claudication, if we summarize all the possible causes, you have neurogenic, musculoskeletal, vascular, and other. Neurogenic spinal stenosis, peripheral neuropathy, peripheral nerve pain, spondylolisthesis. Neuropathy is usually very diffuse pain, which doesn't have any radicular street of pain and which is always with a lot of sensory disturbances, which are not typical for the herniated discs. Musculoskeletals can be arthritis, hip, knee, symptomatic Baker cyst, chronic extensional compartment syndrome, stress fractures, mesospasms. Vascular, several different vascular problems can lead to this peripheral arterial disease, the most common, limb-threatening ischemia, venous insufficiency, deep venous thrombosis, and non-atherosclerotic arterial disease, and restless leg syndromes, and of course, malignancies. So differences between neurogenic and vascular claudication, metastatic spine disease. We've talked about neurogenic claudication. Vascular claudication is usually located at thighs and calf. It's a cramping pain. It has a walking specific distance, exacerbating activities. It stops on walking it leads to pain relief leads to cessation of walking and exercise, and plain radiographs are usually normal for age, and metastasis can lead to pain anywhere along the spine. It's a non-specific pain in relating to activities. It's rare that there is any pain relief without medication. And in radiographs, in plain radiographs, you can usually see lytic lesions in vertebra. And if you are thinking on any vascular problem, it would be great to call a vascular surgeon as soon as possible. But there are also some things which can speed up the differential diagnosis. Deep vein thrombosis, acute arterial occlusion, with temperature of the leg, the color, if it's pale, if it's normal, if the pulses are present or absent, is the venous pattern is distended or it collapses. So here's again differences between neurogenic and vascular claudication. I had in my career several patients who were triaged in the emergency department as patients with herniated disc, but they had an aortic dissection or an acute occlusive arterial disease or a vascular problem. People with vascular claudication usually don't have a history of low back pain. They have a cramp-like pattern, pain pattern post-exercise. It's not affected by prolonged sitting or standing. It's relieved by standing post-exercise. Increase of pain by any exercise, usually no neurological deficits, and abnormal peripheral vascular status. And here is it once more. So if you have a patient with back pain and with leg pain, but it's not following the typical patterns of radiculopathy or of spinal claudication, you always need to think on a different cause. Then there are hip pains. which is also usually provoked by any kind of pressure on the hips. And when you do your plain radiographs, you usually have hips on it. And if they describe a severe coxarthrosis, that's a probably good idea to consult an orthopedic surgeon colleague before doing any kind of interventions of this patient. Then the typical conus medullaris and cauda equina syndrome with bladder and bowel incontinence. So if you have these clusters of symptoms, if you have hyperreflexia, very typical sensory distribution of disturbances, perianal or perigenital, and very early urinary and fecal incontinence, impotence, that's something which can lead you which needs to prompt an urgent imaging and then an urgent intervention, regardless of the cause, either it be a very severe spinal canal stenosis or more often a herniated disc or a metastasis. And then there are three types of problems which occur very common and imitate radiculopathies and imitate back pain: disc-related problems, facet joint-related problems, and sacroiliac joint-related problems. Facet joint pain usually leads to unilateral pain, traumatic and sudden onset, increases with twisting or arcing the body, may have referred pain to the buttocks or back of the thighs. This referred pain is very important in terms of differential diagnosis of leg pain. Aggravating activity, standing, walking, bending backwards. Easing factor is sitting, and local muscle spasm with lower back and hip muscles. Then there's also discogenic pain, anterior spinal elements. Flexion increases pressure. So in a discogenic pain, flexion will lead to increased pressure, and posterior spinal element extension increases pressure. So if you want to differentiate between discogenic and facetogenic pain, you always need to ask these three questions: pain with bending forward, sitting too long, pain with walking downhill, or pain with going upstairs. Facet joint pain tends to worsen with certain movements, arching the back, twisting, standing for prolonged periods, and disc-related pain might worsen with flexion or bending movements. And one good way in differentiating facetogenic pain from any other pain are the blocks. So also in many cases, if you don't have a really good correlation to the patient's symptoms of back pain and leg pain, you can always perform a series of blocks, facet joint blocks, nerve blocks, which can then lead you to the diagnosis what is actually the cause of the patient's pain. You have sacroiliitis and sacroiliac joint or iliosacral joint dysfunction versus lumbar disc problems. Sacroiliitis is inflammation of the sacroiliac joint, commonly due to injury, arthritis, or scoliosis. And key symptoms are lower back or buttock pain, delay from sitting to standing, and tender joint. And in dysfunction of the sacroiliac joint, what we usually see more due to misalignment or instability due to ligament instability or pelvic imbalance, you have usually pain in lower back, hip, or thigh, radiating discomfort down. So this is this referred pain, and SI joint tenderness or stiffness. And lumbar disc problems lead to lower back discomfort, pain may worsen with bending, and key symptoms are lower back discomfort and pain worsening with bending compared to these two SI joint problems. And there's at the end, piriformis syndrome, a very underdiagnosed syndrome, which is a dull ache in the buttock. It leads to pain down the back of the thick calf and foot, imitating sciatica. Pain when walking upstairs or in inclines, increased pain after prolonged sitting, and reduced range of motion of the hip joint. This is very common in taxi or Uber drivers, truck drivers, people who sit most of the day while working. And the diagnosis is usually set as an exclusion. If you excluded all other cases, there are possibilities to perform an ultrasound of the buttock where you can see the enlarged piriformis muscle. There are nerve blocks which can be performed, but also some surgery, but it usually reacts very well to physical therapy. So thank you very much. And my presentation is over.
Maurizio, for your comments, please.
My comment is that, well, we should take in mind that there is a great difference in between midline pain and radicular or spinal cord pain. If you have only midline pain, which means cervical, thoracic, or lumbar pain, in most of the cases, you will not find any specific finding, any neurological finding in the patient. So it's true that there is an enormous amount of examination which are done without a real need, but you're still scared that you're missing some diagnosis, such as tumor, such as inflammatory disease. So what I mean is that if you have some neurological complaint, radicular or medullary complaint, the examination first and the diagnosis afterwards will be easier. If you have only midline pain, you're a bit blind in judging the disease which is going on. And the physical examination, if you have no major deformity, it's very often of poor help. And also, I think that this enormous amount of scale to evaluate the patient preoperatively and postoperatively are not so easy to be used, and there is an enormous amount of subjective conditioning of this scale. In any way, I think that if you have a radicular pain before surgery, the elimination of the cure of this radicular or medullary complaint, if you have neurological complaint, the evaluation of the patient first and of your results will be more accurate. And so I think it's a more philosophical consideration, but I think that in everyday practice, you find this very, very often like the most important truth.
Yeah, you're absolutely right. So recently I had a patient. He's a dentist, and I had operated him for a lumbar disc 10 or 12 years ago. And now he started having pain in the back with radiation to the leg for last 5, 6 months. And it was very difficult for him to do his work because he was a dentist and he had to bend. And so MRI showed there was some foraminal stenosis at L4-5 on the same side where he had pain. It was not too convincing. There was no listhesis, but the pain was significant. So we gave him a root block. Did not help. He got a facet block. He got a SI joint block. He was diagnosed as piriformis syndrome. Nothing worked, and so we were contemplating reoperating him. During that time, he just met with the chiropractor and he just manipulated his muscles, and his pain was completely gone. And it's been now 2 months, and he's completely pain-free. So this is the right message. We should not jump into surgery, and we should exclude all other possibilities before.
This is true, but I want to give also an optimistic opinion about our surgery, because it seems that it is impossible to have good results, or at least to evaluate our results. I think that if you're just giving surgery to someone who has a real disease and a good explanation for his complaint, in most of the cases, you will have good results. And there was a sentence by Professor Benzer who was saying, spinal surgery is unforgiving. And I do completely agree, but in both sense. Either if you're doing good surgery, you have in most of the cases good results. If you're not doing a good surgery, you will not have good results. But if you are accurate in the diagnosis and in the indication, I think that the results, in spite or beside all the scale, most of the cases are very good. As a matter of fact, it's spinal surgery. It's raising quite a lot, just because in the large majority of the cases, the indications are better, the patients are more cautious about what they're going to do with the surgeon, and also the surgeon are more accurate in their diagnosis and their treatment, and the technical support gives the chance to a very, very good result. So It's very important to evaluate the patient, but in many cases, you have the need also to have imaging, neurological imaging. And if there is a proper diagnosis and indication, I repeat, the results in most of the cases are very good. And everybody is experiencing something like that. Of course, there are also bad results with no explanation. This is true. But if you reduce the indication to patients who have a clear disease, the result will be good, I guess.
Yeah. But what I want to say is that learning the patient evaluation in spinal disorders are much important than learning the operative techniques. So, because many mistakes are being done for the lack of good patient evaluation.
Yeah, I do agree.
Yeah. Salman is with us. Maybe he wanna comment on something.
No, I totally agree. I think making sure you have got the right diagnosis, and you can easily do that from what we have just learned right now. I think some very good tips. And then on top of it, if you're sure that you have the facility, do the right operation instead of doing just the operation would be the best way to go. So, I'm very happy that we learned all the basics here today.
Thanks a lot, Sandeep and Maurizio. I think we are 5 minutes past our dedicated time. Do you
Excellent.
want to say something to finish before finishing?
Mehmet, excellent job. I think both you, Maurizio, I think the speakers have done a good job. Sandeep was okay. So maybe Maurizio, I'd let you finish.
Well, just to say goodbye to everybody and to my friends. I hope to meet you very soon. And be cautious, be really very precise in making your diagnosis. And also, Professor Adi was saying, try to treat patients who have a lot of disease, not patients who have minimal disease. If you want great success, try to treat patients who have great disease. This is my opinion.
Thanks a lot, guys. It was a great panel.